think you're on mute. There you go.
We're gonna do this together. So I'll talk about some stuff. She'll talk about some stuff, and it'll be a great conversation with our experience. So if it's okay, we'll start to share our screen. Are you seeing the session with the notes, or are you seeing the other?
We're seeing the notes, unfortunately. So can we switch screens?
Okay.
That's great.
All right. So thank you for the introduction. Dr. Mitchell and I are very excited to share our experience at our comprehensive MISC and COVID pediatric follow-up, just looking at cardiac involvement from the whole spectrum, from the virus itself to MISC and now the vaccine myocarditis. And so in this talk, we're going to take you through those three of the spectrums of disease. So looking at the COVID-19 pandemic, coronavirus is caused by the SARS-CoV-2 virus, and it's disproportionately affecting adults. If you look at this data from the CDC as of September 28th of 2021, the kids are highlighted in yellow, and you can see that the cases, both red are the cases, blue are the deaths, and in proportion to the gray, the percentage of the population they are, they're infrequently affected as kids, and there's very, very few deaths. You can't even see the blue bars here on the death side for them. And so whereas the pediatric reports are kind of describing these low infection rates, infrequent PICU hospitalizations, there are kids who do get sick. And so what do they look like? So in our experience, early in the pandemic, looking at January through April, we looked at 65 hospitalized children. 35% of them required the ICU, with 5 children, or 8% totally, requiring mechanical ventilation, and 12% requiring vasopressors. The median length of stay, though, was 5 days. Looking at illness severity on the left by age category, and then on the right by kind of risk factors, HI being healthy infants, HC being healthy children, IC being the immune compromised, and CI being the chronically ill, sometimes trach vented. We could see here that serious infection, severe infection, as defined by need for mechanical ventilation or vasoactives, were seen in kids greater than 12 years old and in the chronically ill. Wanting to take a closer look at who gets sick, as although very infrequently, there are a portion that goes to the ICU, we took a closer look at the ICU group, and we were able to show here, focusing in on that group, that 47% had some evidence of cardiac dysfunction. What did that mean for these patients? We assessed in later studies, but some of the predictive values for cardiovascular dysfunction, among other things, were initial CRP, ferritin white count, and platelets. Taking a closer look at this group in a paper under revision, this did compare MISC to COVID, but specifically focusing on the SARS-CoV-2 infection in the PICU. There were only 6 patients, even though there were 50% of those 30 patients affected, 6 that actually required vasoactive. Some were just hypotensive or had lactates. Echocardiograms in those 6 patients requiring vasoactives, 3 had normal LV function, as defined by ejection fraction greater than or equal to 55%, and 3 had mildly depressed function, defined by an ejection fraction 45 to 55%. Troponins and proBNP were elevated in the cohort, as been the experience in general. To update, since November 2020, only 13% are now in the PICU. Unclear if this is now the new variant, some immunity, but 20 of the 153 children that we have taken care of now since November 2020 are in the ICU, and only 1 patient had LV dysfunction with inotropic needs. Our experience has been actually kind of confirmed in subsequent multi-centered studies, this one being the first one out of JAMA looking at PICU, because again, the kids are infected, but rarely do they get sick, and this kind of confirmed that. In this cohort of about 50 patients across 40 centers, the predominant presenting feature was respiratory, and in terms of who needed intubation, again, 38%, a very few amount needed intubation, with 25% having vasoactive support. And they concluded that as far as COVID goes, kids had a far greater risk from flu than they had from COVID. So we thought we were in the clear. Perhaps it didn't mean anything in terms of the long term for these kids. And then out came this paper for adults, just looking at adults with mild to moderate infections, not hospitalized. They got an MRI and there was edema and scarring of their heart. So what does this mean? Are we missing myocarditis? And this paper that came out of Ohio would suggest so, looking at competitive athletes' MRIs recovering from COVID-19 infection. So when looking at this group, there were 26 competitive athletes with mild or moderate symptoms, mostly male, no EKG changes, troponins, or decreased LV function suggestive of myocarditis, but 14% met the MRI Lake Louise criteria for myocarditis. And so this suggested that we should risk stratify return to play guidelines with MRIs. Fast forward now to 2021. This report, coming out in January, evaluated myocarditis again in competitive student athletes. They looked at 125, again, mostly male, asymptomatic to moderate symptoms, looking at the MRI around 15 days. And their MRIs, only 2 showed evidence of acute myocarditis, and one of them had abnormal troponins. Perhaps what they were seeing in that prior study, there's non-specific late GAD enhancement that could be described in association with athletic training. So perhaps we don't need MRIs for clearance. Another paper looking at 26 athletes and Olympians, getting the females on the mostly end of the spectrum. There was no acute myocarditis in this group, again, looking at MRIs 30 days after illness. There was some acute edema. This was mostly kind of borderline, but you can see edema after running a marathon, and edema, as we know, for pre-COVID myocarditis with direct viral infiltrates does not predict prognosis. And so perhaps, again, we don't need MRIs for sports clearance. This JACC review topic, looking at evidence for SARS-CoV-2 infection as a cause of myocarditis, on the right-hand side of the screen, you can look at autopsy specimens for myocarditis, which we traditionally define as inflammatory cells of the myocardium, mostly T cells that actually destroy, and you can see necrosis of the cardiomyocytes. When they looked at COVID-19 infection, the COVID-19 infection looked very similar to controls or a traumatic cause of death, where you had inflammatory cells, mostly macrophages, but none of them actually caused myocyte death, suggesting that perhaps, we're overcalling myocarditis, and perhaps MRI is just seeing the infiltrate, but not necessarily tissue death, which is what we worry about in terms of prognosis and return to play. There are many return to play guidelines out there, algorithms stratifying by age, which you can see on the left, or again, athletic static and kind of severity of symptoms, if you will, seen on the right. And really for severe symptoms or anybody with moderate symptoms, they're looking at MRIs and trying to restrict play for 3 to 6 months. So in our experience over the course of the last now year and a half, we had no persistent cardiac abnormalities on follow-up after discharge from COVID. The cardiac evaluations for non-hospitalized children infected with the SARS-CoV-2 virus have all been normal. And then initial MRIs that we were performing based on these recommendations for varsity athletes, we did not see myocarditis or late gadolinium enhancement. So our present practice is to encourage pediatricians to assess illness severity and cardiac symptoms. If there are no cardiac symptoms, it's okay for the PMD to clear, whether they had mild, moderate, or if they were hospitalized, especially if they're non-athletes. Let the kids go to gym, get them off the couch. If they had moderate to severe symptoms in athletes, we would like the pediatricians to refer. And our present practice has adopted over time, but for athletes with moderate to severe symptoms, we get an EKG and echocardiogram. If you're going to go play sports at the true varsity NCAA level, we'll get an exercise stress test, but routine cardiac MRIs have kind of fallen out of favor, at least in our institution, because they had not been predictive of both prognosis and return to play in pre-COVID myocarditis or now. So in summary, although infection with the SARS-CoV-2 virus is usually mild, what we saw later, 4 to 6 weeks later, was that cardiac involvement was a lot more extensive and a lot more severe in a disease known as MISC, or multisystem inflammatory syndrome in children, also known as PIMS, or pediatric multisystem inflammatory syndrome in Europe. And so Dr. Mitchell is going to describe a little bit about our early experience with MISC.
All right, thank you, Dr. Capone, for that excellent overview. So I'm going to delve right into our experience with MISC, really encapsulating our first major cohort of patients. But just to really quickly bring up the Centers for Disease Control case definition for MISC, and just to summarize it really quickly here on the right, it's children less than 21 years old, a fever for at least 24 hours, signs of inflammation on our lab values, CRP, ESR, and more than 2 systems involved: cardiac, renal, respiratory, hematologic, GI, dermatological, or neurological. You have to have evidence of SARS-CoV-2 infection, although some guidelines do accept simply a exposure to SARS-CoV-2 and no plausible alternative diagnosis. So at Cohen Children's Medical Center, we are right outside of New York City in Long Island, New York. To date, we've had over 100 patients with this condition, starting back in the late spring of 2020. We found that the age is, in general, ranges from 2 to 17, but the mean is really around 8.8 years. And we certainly see children who are much older than Kawasaki disease, which we'll go into in a little bit. Pretty somewhat evenly distributed, 58% male, 42% female. In terms of the level of care, 21% were able to stay on the general pediatric floor, but 79% either needed direct ICU admission or escalation of care during their hospitalization. So the presenting symptoms, the clinical picture of these patients. One of the major things that we noted really early was the prevalence of GI symptoms. So obviously 100% of these patients have fever, but 88% have GI symptoms of some kind. And what was really notable was how many children seemed to come to us with a presentation that looked like appendicitis or another GI condition, and were frequently, I don't want to say misdiagnosed, but early in their course, a GI condition was higher on their differential. But as time went on and as more symptoms became more evident, we saw the remainder of these symptoms. Neurological symptoms were quite common: irritability, lethargy, and headache. Rash was common. What was not as common as compared to the typical COVID disease was respiratory symptoms. While some kids did come in with dyspnea, most of them did not have respiratory symptoms. This was, especially at the very beginning, thought to be a version of Kawasaki disease because of the similarities. And as you can see here, 64% of our cohort qualified, 64% of our cohort met the criteria for complete Kawasaki disease. These children were quite sick, with 73% requiring inotropes or vasoactives. Labs were significant for significant inflammation. CRP, which is a median of 206 in our cohort, is quite high. We also found elevation in troponin and BNP. With troponin, about 68% of our patients had an elevated troponin level, and 74% had an elevated BNP. So moving on to our echocardiogram, and sorry to jump right into some pictures. This is certainly my area of greatest love, so sorry if I embellish this a little bit, but what we saw in the echocardiograms was truly remarkable, and I really felt as if we were seeing what people had been seeing with Kawasaki disease for many years, and all the traits that people talked about with Kawasaki disease when it comes to coronary artery abnormalities and mitral regurgitation. It all became so obvious why all those different aspects were included in the criteria. But to start off with, many of these patients had decreased LV systolic function. The average LV ejection fraction was 53% with a range of 36 to 72. Out of our entire cohort, 52% had LV systolic dysfunction. with 28% having mild dysfunction and 23% having moderate dysfunction. 69% had resolution of this dysfunction in the hospital. So unlike our typical infiltrative myocarditis, which can, very frequently, the dysfunction lasts for a long time, many of these patients recovered quite quickly, and it was quite impressive. In general, we saw some of these patients recover function in 1 to 8 days, but a mean of 3 to 4 days. But it was quite remarkable to see them go from such significant decreased function to normal within a couple of days. So a couple of other really important findings. One was diastolic dysfunction. We found that in our cohort, 34% had diastolic dysfunction in the acute phase. One thing that was quite prevalent and seen very early on is this monophasic inflow of the mitral inflow Doppler, and that's can be a sign of diastolic dysfunction. We didn't see much E to A reversal or other changes with E to A. It was mostly just monophasic mitral inflow. And as you can see, 84% of our cohort had monophasic inflow in the acute phase. Looking at tissue Doppler velocities, to qualify for being considered diastolic dysfunction, these tissue Doppler velocities had to be decreased as well to be included in that 34%. And this is just an example of a patient that did have decreased tissue Doppler velocities. On the top here is the lateral velocities of 0.11 meters per second with a ratio of 9.66, and the septal velocity is 0.09 meters per second with a ratio of 11.78. So another prominent finding that a lot has been reported on is the coronary artery abnormalities, the coronary artery aneurysm and dilation. We considered it aneurysmal if the Z-score was greater than 2.5. And this is an example of 3 patients who have aneurysms. In this first patient, the LAD seen right here had a Z-score of plus 2.7. Down here, I'll try and slow this down a second. The right coronary artery is aneurysmal, as you can see here, and that had a Z-score of plus 3.3. And then finally, just a still image of the left main and left anterior descending coronary artery of a patient, and the LAD had a Z-score of plus 2.9. In all, we saw dilated coronary arteries, which was a Z-score of 2 to 2.49 in 8% and aneurysmal in 16%. But the other thing that we saw in addition to this, which was harder to quantify, but certainly something that was quite notable, was abnormal appearing coronary arteries that measured within normal limits. As you can see here at the bottom, both the left main and the left anterior descending coronary artery clearly are abnormal, but measured within normal limits. Previously used terms like lack of tapering, we brought back a little bit, even though we didn't love that term because it's so non-specific and can't be quantified. But a lot of us were using that term again, along with just prominent coronary arteries due to the fact that there was just something abnormal with these coronaries. But when you measured them, technically on the report, they ended up being fine. What I have seen in these patients over time is that their coronary artery measurements do get smaller over time, whereas the entire time course, their coronaries remained within normal limits, but they're getting smaller compared to their acute phase. And we saw this prominence or lack of tapering of the coronary arteries in 28% of patients in the acute phase. Overall, 52% of patients had coronary artery abnormalities, which is quite significant. Valve regurgitation was quite impressive. Here's just an example of 2 patients that had mild and mild to moderate mitral valve regurgitation. Actually, I believe this patient on the right over time, surprisingly completely resolved this mitral regurgitation. So what we saw in general in the acute phase, 50% had trivial mitral regurgitation, 30% had mild, and 4% had moderate. Oh, sorry, I just skip ahead. Okay, so aortic valve regurgitation was seen in 12% in the acute phase, 6% was trivial, 6% was mild. This completely resolved by early follow-up. And although tricuspid regurgitation is, we see all the time, the tricuspid regurgitation seen in these patients was just not your typical physiologic or trivial tricuspid valve regurgitation. Really just looking at what we considered mild or moderate, 74% of patients in the acute phase had mitral regurgitation, all of which improved over time. Pericardial effusions. We didn't have any patients that had severe pericardial effusions, but multiple patients had trivial or small pericardial effusions with a total of 41% of our cohort. Oops, sorry. And finally, the last really impressive finding in the acute phase is this finding in the aorta of holodiastolic reversal of flow that we saw at the level of the diaphragm. And this was not your typical PDA fever holodiastolic reversal of flow that you would see. This was quite significant, as you can see from these two examples. We saw this finding in 72% of patients in the acute phase. And certainly along with our physical exam and our following of these patients, this was clearly a graphical impression of the peripheral vasodilation that was happening in these patients. They had significant distributive shock. And these Doppler profiles absolutely correspond to what we saw in person. So just to think about the type of shock that these patients have, we really saw that these patients had a combination of both vasodilatory shock and cardiogenic shock, with the significant peripheral vasodilation, that significant holodiastolic reversal of flow, along with the systolic dysfunction and diastolic dysfunction. I think it's important to point out the peripheral vasodilation because many of these patients require multiple fluid boluses. And in a patient with typical myocarditis, that's just simply cardiogenic shock, you don't want to give fluid boluses multiple times, but these are patients that require fluid boluses, inotropes, and peripheral vasoactives. So just moving on to how we treated these patients, I'm going to turn this back to Dr. Capone, and she'll talk about our treatment pathway.
Thanks, Dr. Mitchell. And so early on in the course, Dr. Mitchell kind of described the presenting features. And so we highlighted these for our ED and our pediatric colleagues. And so if you arrive to the ED or urgent care, or anyone in the Northwell facility with fever greater than 38 for 4 days or equal to 4 days, and any one of these symptoms, you fell into this algorithm. And we sent all of these labs, and we do have the luxury of sending all of these labs here in this academic institution. But as you saw, these labs seem to correlate not only with a specific profile for MISC, but even probably illness severity in some of these cases. If these results were normal and the pattern didn't kind of fit the pattern that Dr. Mitchell showed you earlier, you had routine care or a COVID person of interest algorithm instead. If any of these were abnormal, that sparked an infectious disease and a cardiology consult. And we had indications for this specifically on the reverse side of this algorithm. Multisystem inflammatory syndrome in children was defined as the fever, inflammation, and we kind of tried to look at the phenotypes of this disease. It's been described as having similarities to hemophagocytic histolistiocytosis, to Kawasaki disease, and to toxic shock. And so we divided them into those categories with criteria, but in general, MISC with shock, with typical KD features, incomplete, and then a bundle in the beginning that we don't know what to do with. And if we had to revise it today, we could fix this so that that category doesn't exist because we have a lot more data on their uniformity. If they had shock where you needed fluid refractory in the beginning, but any kind of fluid actually towards the end, and you'll see why as we go through the data, sparked a high risk patient. If you had decreased LV ejection fraction or carditis, like Dr. Mitchell just showed you on those echocardiograms, again, you were high risk, you were admitted to the PICU. If none of those things were present, you were admitted to the floor. If you were high risk and admitted to the PICU, we tried to stratify your dosing of a steroid that we gave based on how sick you were, using vasoactive scores, how quickly we had to increase your vasoactive, the general gestalt of the patient. And so steroids were dosed either as 1 per kilo all the way to pulse if we felt we needed it. IVIG and aspirin, again, taking notes from the kind of Kawasaki pathway, were given to everybody. And if your fever didn't resolve after 24 hours of an IVIG infusion and your ferritin was greater than 800 or your echo was worsening despite the fact that you were afebrile, anakinra was added to the regimen again because there's phenotypes that look like HLH. Lovenox was actually used heavy-handed here in about 40% of patients based on hematology. This was in general D-dimers greater than 1,000 in particular, and then with additional dysfunction. And again, this is because there was some thromboembolic phenomena reported associated with the severity of COVID illness. And so we added this to our protocol and regimen. If you look at our kind of less severe criteria, you have IVIG, you have a higher dose of aspirin, and then steroids are reserved for those with coronary abnormalities, but not carditis, decreased function, or shock. And then here with coronary abnormalities or with just other symptoms, just like eye finding or something like that, we would lean on not anakinra, but on the usual infliximab or Remicade for those patients. Again, looking at the Kawasaki and trying as best as we could to risk, stratify, and treat based on phenotypes. Our suspicions have been confirmed now. This came out, I think, about a month or two ago. Again, looking at a multi-centered study, MISC, initial therapies and outcomes with the overcoming COVID investigators, so multiple sites throughout the US. And IVIG plus steroids had a better outcome, and outcomes here were defined as no cardiovascular dysfunction or decreased cardiovascular dysfunction after 2 days. So if you got IVIG and steroids, you were less likely to develop cardiac dysfunction after 2 days of admission than if you did not, if you just used IVIG alone. Secondary outcomes included recurrence of fever, need for adjunctive therapy again after 2 days of admission. If you just received IVIG alone, you were more likely to need adjunctive therapy. You're more likely to have shock. You're more likely to have LV dysfunction. And again, they did probability weighted analysis to, again, risk stratify in multiple ways, kind of showing in this, this forest plot the benefit of IVIG and steroids. France came out with this in 2020, again, a multi-centered. IVIG and steroids were a lot better than IVIG alone. It prevented use of second-line therapy, need for hemodynamic support, left ventricular dysfunction occurring after initial therapy with IVIG, and duration of stay in the PICU. This seems to suggest that actually timing of treatment would actually matter in this case. And actually, Dr. Mitchell and myself, along with some multi-centered study sites in New York, are looking to see, because we treated kind of homogenously, if we could associate time to treatment with outcome. In terms of medications used, we described this in our first report of the 33 patients, of 33 patients, and that was in this paper that I clipped up here. However, in the paper I'm about to go over with you, we had 50 patients by the time August and September hit, when we were kind of reviewing them. And so 96% of patients were treated as per the guideline, 96% getting IVIG, 70% getting steroids. Biologics were given in 26%, aspirin in 92, and Lovenox in 46. Again, we really just missed 2 patients early on, and those were both PCR and IgG positive. And so at first we didn't know if they were COVID versus carditis, and then that became apparent. They were the initial kind of propagators for this. So in terms of our short-term follow-up, we followed the model for Kawasaki disease and myocarditis. They were discharged on low-dose aspirin with a steroid taper if they got it during the acute phase. And if they were given Lovenox in the hospital, they got Lovenox if they were young as an outpatient, but if they could take pills, they got Apixaban or Eliquis, as you know it. They were followed at 2 weeks, 6 to 8 weeks, 3 months, 6 months, and 1 year. So following them up at 6 months with this paper published in Pediatrics, we looked at 50 children admitted from April to June of 2020 with follow-up again at 2, 8, and 6 months post-admission. Demographics and labs were described previously by Dr. Mitchell. 66% of this cohort had cardiovascular manifestations, 52 with decreased function requiring vasoactives. 14% had coronary Z-scores that were dilated or aneurysmal with a Z-score greater than 2. 96% were treated with our guideline. There were no in-hospital deaths, no patient required ECMO. So looking at our 6-month follow-up and ejection fraction just over time, you can see we start off in the admission hospitalization here with median or ejection fraction around 53%, so somewhat mildly dysfunctional. By discharge, that's the orange, the majority had resolved, about 70% had resolved. By 8 weeks, almost all of them have resolved. And you see this just general kind of uptick in this kind of tightening of the ejection fraction to more normal, kind of again demonstrating a rapid resolution and something that was more post-inflammatory and inflammatory response to a critical illness rather than the typical kind of pattern of infiltrate myocarditis with necrosis that we see. Looking at the coronary arteries in follow-up, and we have the left main on the left and the LAD in the middle and the RCA on the right. The red line indicates a Z-score greater than 2. And so all patients, if you look at the blue, the acute phase, were relatively dilated compared to 6 months. And that's not surprising. Papers have before shown that coronaries can get dilated in times of fever or in systemic inflammation. And we're showing that again visually here. But you can see as the kind of whisker plots, box plots kind of extend past the line, we did have some aneurysms in the left main LAD and the RCA, and those resolved by the 8-week follow-up in all patients. And there were no patients actually that had coronary problems that did not come back to follow-up, and there were no patients who had aneurysm, who did not have any aneurysm that developed aneurysms after the 8-week follow-up. So our findings were again confirmed in this multi-centered study. This only looked out to 30 days, but this was 500 patients. Again, the Overcoming COVID-19 Investigator Group in the US. And so ejection fraction is the Kaplan-Meier is on the left and coronary arteries are on the right. 90% of patients with a decreased ejection fraction at admission and 80% of patients with coronary artery aneurysms normalized by 30 days. This paper did not go out beyond 30 days, but getting a sense for kids pretty much do well. This is a paper by Dr. Faruqi et al. From Columbia, again, kind of 50 patients or 45 patients in this case, but very, very similar findings to our own, where at 4 to 9 months, only one child in their group had persistent mild dysfunction. And so kids seem to be recovering. And this paper had some notable differences because they looked at cytokines for people who are interested in the cytokine profile and how that resolved in this cohort. So what does that mean for return to play then? These kids were really, really sick. We were calling them myocarditis. Their follow-up seemed to suggest that they're not truly viral infiltrate where they're necrosing, rather a post-inflammatory. So carditis, not a myocarditis that needs them to be sitting out. And so in our 6-month follow-up paper, we also reported on MRIs, and we performed MRIs in 11 patients with LV dysfunction and troponin elevation during the admission. Yes, we did have more, but we did not MRI people who needed sedation or anything like that. And we specifically picked those with LV dysfunction and troponin elevation to see the highest risk cohort for myocarditis. There was no persistent edema or fibrosis in any patient. There were no coronary artery dilations or aneurysms. And these MRIs were all done after or around 8 weeks in the convalescent phase. So this is suggestive of a post-inflammatory carditis and quite a favorable prognosis. And a big thank you to Dr. Misra from our group for the help kind of coordinating the care of this and getting this out there. Again, this is confirmation of some of what we've been seeing in case series that are out there. This is looking now acutely. We didn't study acutely, but the cardiac MRIs of children with MISC, and there was diffuse edema in the acute phase, so less than 4 weeks, or around or less than 4 weeks. But there was no GAD and there was no Lake-Louise criteria for acute myocarditis, again suggesting acutely, at least in these 4 patients, that this is a post-infectious phenomena. Further confirmation through this particular study, 19 children done after 8 weeks. And here there was no persistent changes on MRI in these children, supporting the hypothesis that cardiac involvement is a form of a transient inflammatory response. And then last, the most recent, again, MRIs here from symptomatic patients. They had normal cardiac MRIs and normal biomarkers at their follow-up. And so this was in 17 children, again, suggestive of a post-inflammatory response. So in our experience with return to play, if their cardiac function was normal and their troponins were normal on admission, then they could return to play if their EKG and echo were normal at 8 weeks post-discharge. We also had some labs are reported in the paper, and those labs had normalized by 8 weeks in majority. Sometimes platelets were a little high and they lingered, and so we kept aspirin on. If the LV ejection fraction was low on admission or there was a coronary aneurysm, right, you could return to play if you had an EKG and echo that were normal at the 8 weeks post-discharge. But if you're a varsity NCAA athlete, because of just, again, crossing our T's and dotting our I's with a stress test, and then return them to play. But we moved away actually from routine MRIs for these patients. And so speaking of MRIs, and to close this up, myocarditis associated with the vaccine is going to be discussed by Dr. Mitchell. Thank you.
Thank you once again. So now that we've gone over all of our information on COVID and MIS-C, now to the final and most recent topic, which is the vaccine-associated myopericarditis. Just highlighting a recent paper from Pediatrics, which really reflects our experience here at Cohen Children's, and also has one of our own here in the list. Dr. Neela Misra was a part of this publication as well. But what they found was that exactly what we're seeing, that teenage boys are coming in a couple of days after a vaccine dose with chest pain and signs of myopericarditis. So the age range is 12 to 20 years with a mean age of 15 years. 92% are male. The vast majority of the time, this is after the second dose. In this pediatrics paper, all but one patient had come in after the second dose of the mRNA vaccine, with one patient coming in after the first. Other case series have shown maybe a couple more after the first dose, but the vast majority come in after the second dose. The onset of symptoms is a range of 0 to 7 days, but a mean of 2.1 days. And that really reflects what we've seen as well. Kids typically come in 1 to 3 days after the vaccine. The symptoms that these children have, chest pain is the most prominent symptom and sometimes the only symptom. And very frequently we found that the chest pain is consistent with pericarditis, with worsening with lying flat, improvement with sitting forward, improvement with NSAIDs. Some patients have also come in with fevers, myalgia, fatigue, and that does point out one very important distinguishing factor between the common reaction that people get to the vaccine. I'm sure a lot of you have known plenty of people who have felt ill for a few days after the vaccine with fevers, myalgias, fatigue, but they don't have chest pain. What distinguishes these patients who have the vaccine-associated myocarditis or myopericarditis is the chest pain. And I emphasize that to all of my patients that are concerned about the vaccine, concerned about symptoms that they might have after the vaccine. If chest pain isn't involved, likely not a factor. These patients also have elevated cardiac enzyme levels, troponin and CKMB. And it's really important to always check for both. Obviously, everybody's lab is different with troponin, whether it's T or I, and what type. At our lab, we do high sensitivity troponin T, and we always make sure to include the CKMB as well, because that can help predict a true improvement. So the EKG findings in these patients, let's see. So with this first one, we're basically seeing ST segment changes throughout all of the leads with both elevations and depressions as well. In this EKG, this was actually one of our first patients that came in, had significant ST segment changes, particularly in the lateral leads, lateral and inferior leads. And then one other common EKG finding is inversion of T waves, as we see here in V4 through V6. The paper in Pediatrics found 70% of all patients in their cohort had EKG abnormalities. So it is important to see that there are some patients that do not have EKG findings. Some I've even seen some conversations and colleagues talk about someone not having the vaccine-associated myocarditis because their EKG was normal, but it's important to not brush that aside, even if the EKG is normal. Another very prominent finding in these patients is the normal LV systolic function, and that was something that was noted very early on, that all these patients were coming in with either completely normal LV systolic function or maybe mildly decreased. And in this paper, they found 86% had normal function, 14% had mildly decreased LV systolic function. In terms of the MRI findings, and I would like to note very quickly that we were getting MRIs on patients that may not typically have gotten an MRI. If you had elevated cardiac enzyme levels, but a completely normal LV systolic function and no arrhythmias, we may not get an MRI on such patients. But because of what everyone had been hearing about this new clinical entity, we were doing MRIs more frequently, and we still continue to get MRIs if there's a question between myocarditis and pericarditis for the predictive values. So this is also from the Pediatrics paper. You can see these top two images show that the T2 weighted images have increased intensity in the myocardium as compared to the skeletal muscle that you can see right here. I hope you can see my cursor. In the bottom two pictures, bottom left, T2 mapping shows areas of elevated T2 here with the black arrow. Hope you can see my arrow as well. This correlates with an area of late gadolinium enhancement that you can see right here. In their study, 88% met criteria for myocarditis. The other findings, although not as prominent as some of the other findings, arrhythmias, non-sustained ventricular tachycardia in cases of complete heart block that are seen in the hospital. And there have been other anecdotal reports of findings of non-sustained VT on Holter monitors on follow-up as well. So we have been Holtering all these patients at their first follow-up. The treatment has been a major question. This was certainly a major question for us when we got our first patients. How are we going to treat this? The treatment of myocarditis in general is still up in the air and highly controversial between IVIG and steroids. But whether or not we even treat it like myocarditis or pericarditis was a huge question. At our institution at Cohen's, we have been treating with a course of NSAIDs, 7 to 10 days, along with stomach protection to make sure that they don't get gastric ulcers. And in this cohort, 86% received NSAIDs, 23% received corticosteroids, and 23% received IVIG and 24% corticosteroids. There have been multiple reports of people not treating with anything and the patient's still recovering. Any patient that has elevated cardiac enzymes, we admit to the hospital for telemetry monitoring as well as monitoring of cardiac enzymes. And as I had mentioned before, I always think it's very important to obtain both troponin as well as CKMB. We found that in these patients, the troponin levels tend to fluctuate tremendously, whereas once the CKMB levels start to decrease persistently, then you know that the patient is on to recovery. And lastly, in our state of New York, the Department of Health put out a guideline for avoiding the COVID vaccine in patients with myocarditis, in that if a person has myocarditis or pericarditis unrelated to COVID-19 that is not yet resolved, to hold off on receiving the COVID vaccine. And for any patients that received myocarditis or pericarditis or had myocarditis or pericarditis after the first or second dose of the COVID vaccine, to hold off on receiving a subsequent dose until further data is available. So that is our information on the vaccine-associated myocarditis. I believe we've had about 12 patients here at Cohen Children's so far with this condition. And the good news about all these COVID-related cardiac entities in children is that in general, the kids do well. Even though these kids can get very sick with MIS-C, there can be significant findings with the COVID-associated, vaccine-associated myocarditis. In general, these children have been doing very well, but there's still much more follow-up to be done. Dr. Capone and I had the outpatient follow-up clinic here at Cohen Children's Medical Center, and we've been following children either who have been admitted to the hospital for SARS-CoV-2 infection, any patient with MIS-C, as well as we've been seeing multiple patients who have had an outpatient course of SARS-CoV-2, but many of our other colleagues have seen those as well. And now we're seeing the patients with the vaccine-associated myocarditis as well. We have a great team and great coordination with the infectious disease group, the hematology group, and the renal group as well, who we all follow these patients. And thank you so much for letting us share our experience. And I guess at this point, we can turn it to questions.
Thank you so much, Christine and Libby. I know we have people from all over on the phone call, and I was wondering if people have questions for them specifically about diseases. If you want to share your own experiences, perhaps you can take your slides off, stop sharing your screen, guys, and we'll take a look at everyone. So how's it been going other places? Have you been seeing MISC, New York had that big peak, and then we seem like we're relatively protected, but other people are all around the country and certainly outside the country. And Ken, have you been seeing stuff? Maybe Ken left. Our friends down in Peru. What do you think this is, Christine? Do you think this is edema?
Yeah.
I think it's like edema.
At the beginning, I wasn't sure, but I think more and more evidence, particularly for MISC, is showing that this is edema. And then for some of the, at least there's some I do take care of, one who had true both Lake Louise symptomatic, genuine SARS-CoV-2 myocarditis, but some of just the plain MRI findings that we're seeing in the outpatient setting, I think is just edema too.
Has anybody biopsied patients?
Not us,
adults
have. And so that paper that was in JAC actually reviewed some of the biopsy and the autopsy findings as well. So there's some evidence of biopsies in there as well. And biopsies.
Is there actually the same myocarditis or not so much? Or?
They're not.
I guess like we're not seeing cellular infiltrates, more like a reaction to the vasculitis as opposed to lymphocytic reaction against the myocytes themselves, where you're coming in like transplant rejection, where you think those lymphocytes are actually going in to kill myocytes.
Daphne, it's interesting because that's exactly the conversation the three of us had a few days ago about how that's really is the sort of paradigm I think we're thinking about here. As opposed to that sort of, it's biphasic, much like the regular myocarditis, but much more of the secondary MISC is edema and inflammation and not infiltrative.
Yeah, because you look at sepsis, just regular sepsis, and you do echoes, 40% of them would have dysfunction in just pure bacterial sepsis. And that's not, again, it's not myocarditis. That's just the whole body's vascular system is just going nuts, right? And leaking everywhere. And then if you get that, so you're interesting with diastolic dysfunction you're seeing, right? You're seeing that just as much as you're seeing any other issues. And so then you can't fully,
Another thing we see in these patients that we haven't had the greatest way to quantify, but pleural effusions. I think that these patients, both from getting lots and lots of fluid, they need it because they're vasodilated and they need that fluid. But just like you mentioned, they start leaking, and many of these patients have pleural effusions. Yeah.
So
and I think,
you mentioned sepsis.
Oh, sorry, go ahead.
So Daphne, you mentioned sepsis. What's interesting in sepsis in comparison, though, is that sepsis, typically has an increase in a lot of your pro-inflammatory cascade cytokines like TNF and IL-1 beta. You don't really see that with MISC to this degree, which is quite fascinating because you see the opposite. You see C cell exhaustion with CD4, CD8 depletion of a lot of your lymphocytes and NK cells with changes in some of your STAT3 pathways. I think it's really interesting. I think the other thing that's interesting about all of this is that when you look at the numbers now for MISC that we looked at a couple weeks ago, the incidence of MISC post first wave with alpha and delta variant are actually at a much lower incidence that we saw with the first wave and and actually even with our second B117 variant and D614G. So it really makes it interesting because there clearly is a strain effect on the immune perturbation that's causing this post-inflammatory problem.
Yeah, that is pretty interesting, isn't it? That's what we noticed too. We thought, oh, maybe we'll see another surge. We didn't see anything, compared to what we saw last March. What do you think about the return to play? I mean, I'm kind of not so impressed in the long-term effects of this disease. But there's a lot of reports coming out now, right? The professional athletes and the college athletes reports of COVID infection, not MISC, but COVID infection in these athletes, and they go back to play right away. And you think if they were going to have problems, those people would have problems because they are doing maximal exercise. So I think we need to calm people down like you're doing a little bit about the worries, the long-term worries. That's pretty, it's interesting to have a disease you don't know anything about, obviously.
At least cardiovascularly, they're doing really well. Some of the stuff that we didn't get to cover, but it's going to come because you're following them at the 2, 4, and 8 week marks, is that they don't feel well, right? They're systemically inflamed. So they complain of headaches. They almost like a concussion. They're sleeping all the time. They can't focus in school. And so functionally, they don't return to baseline. They complain of shortness of breath, but they have normal echoes. Now we know they have normal MRIs, and so their shortness of breath, and all of that is just, again, recovery from critical illness and this kind of critical illness, kind of COVID syndrome. And so we do see that, and that's part of it, but kind of these encouraging cardiovascular outcomes are going to help guide that management.
Also help make them feel better. I think something that they're also worried about their heart. So
one of the things that we have noticed that we also didn't get to talk too much about, but they do get some kidney injury because of the vasodilatory component in the beginning and the shock-like state to the kidneys. And so to be published is that there's a subset of them that actually have hypertension. So they're seeing you in clinic, so pay attention to that blood pressure, because even though their hearts are fine now, hypertension in the long run and second hits are probably not going to be good. So if you do see hypertension in your follow-up or referral, because there have been some that needed to be treated.
Any other questions people have? Comments? Well, thank you all for joining. I believe that we are at the top of the hour. Thank you very much, Libby and Christine, for this really interesting overview and fascinating as we look for the future. Hopefully we'll talk less and less about this disease.
Yeah.
And we'll get back to our Heart Care International congenital heart disease trips. I think kind of exciting. You guys went on a little trip. I heard from Dr. Mitchler. You guys went on a trip and did some work, right? That was
we went to Dominican Republic. And we did our smallest child or youngest child, 32-hour-old TGA. And we did 14 and it went pretty well. So we're leaving again November.
November 8th, we'll have a very small team in Chiapas. We're still putting together the pieces for that trip.
fantastic.
And the DR trip, where we usually travel with 30, we traveled with 6 medical professionals. So different trips, but we're trying to get into 2022 more optimistically.
Went exceptionally well in the DR, and we look forward to a great trip in Chiapas.
Yeah, that's fantastic. It's going to be nice to start up again, and perhaps Libby and Christine would like to use some of their expertise on these trips too. It's a great opportunity to share knowledge.
Yeah, and I'll be back soon too. I can't wait.
Yay.
Thanks for hooking us up with your colleagues.
Yeah, thanks guys. That was an amazing overview. I continually learn from you guys every few months that goes by when you paper. So, proud of your work and so impressed with you guys.
Oh, thanks, Denise.
Thanks for helping us out, Denise.
That's
wish
great.
everybody
Thanks.
and everyone on the phone, I hope you're all staying healthy, staying happy, getting back to somewhat semblance of a normal life as we restart. And I hope that we can all see each other in person at some point in the next year.
I hope so.
I hope so too.
Exactly, Betsy.
Okay.
All right. Thank you so much again for having us.
Thank you.
Thank you.
Yeah.
Thank you so
Thank
much.
you.
It's amazing. Thank you.
All right, you'll hear about our next one soon. There'll be an email coming out.
Yeah, that'd be
Bye.
wonderful. Betsy, best of luck to your grandson.
Thank you. Thank you.
Thank you all. Bye.
Bye.
Thank you. Bye.